about now? Is it clear now? Okay. Okay, good morning, as I said before, and I hope for every one of you good health and good day, inshallah. Today, I think it is our last lecture. I will talk about history taking and physical examinations. You know, the history taking from the patient, it means you take the information from patients about his illness. It is not easy. It is not easy job to get informations from the patients which are of different education levels and different intelligence levels. So, in order to be a good history-taking doctors, you should have good informations, theoretical information about your field، يعني باختصاصك، يعني أنت شو تريد تسأل بالضبط. مثلا بالجهاز التنفسي لازم تكون عندك معلومات جيدة عن الجهاز التنفسي، مشاكله، أعراضه. And then the second component, you should be skilled in how to communicate with the patients. يعني لازم عندك المقدرة على التواصل والتفاهم اللغوي والسلوكي مع البيشنتس in order to get the accurate information from your patients. Anyhow, as you know, the most common symptoms related to the respiratory system disease is the following: dyspnea, chest pain, cough, sputum productions, Haemoptysis, and wheeze. All these are the symptoms. You should know it in details, and you should know how is the patients express these symptoms. يعني الناس يستخدمون لهجات مختلفة للتعبير عن معاناتهم. يعني واحد يعبر لك بشكل مختلف عن الثاني، فلازم أنت تكون عندك القاعدة الثقافية والمهنية والعلمية لفهم ما يقول البيشنت مالتك. Okay, so I will go to explain each of them separately. First, dyspnea. What are the dyspnea? Dyspnea is uncomfortable, abnormal awareness of breathings. Usually we breathe and exhale and inhale the air unconsciously, and we didn't feel our breathings. This is spontaneous process, automatic process, doing by our bodies without our feelings. If you feel you are breathe, and this breathe, whether it is difficult or not, we call this dyspnea. But usually the dyspnea يعني involving unpleasant feelings, not pleasurable feeling, unpleasant feelings. يعني مثلا أني من أركض شوية أو أنجز عمل أسوي exertional exercise راح يصير عندي feeling of my breathings because I need more oxygen. لكن هذا الفيلينج is not unpleasant. So احنا ما نقدر نسميه dyspnea. Dyspnea only applied to those patients who feel his breathing is doing unpleasantly. Okay? So what are the most common cause of dyspnea? The most common cause of dyspnea, either cardiac or pulmonary or chest. I mean chest and lung. cause. When I said here is chest, I mean lung disease or metabolic disease. Cardiac and chest is the main cause of dyspnea. Sometimes some book said cardiac cause of dyspnea is most common than lung cause of dyspnea, and other books say the reverse of that. يعني إذا أنا رحت وسويت statistics حسبت إنه ال underlying cause of dyspneic patients اللي يراجعون مركز أمراض القلب، طبعا بشي حالة أكيد راح يطلع إنه معظم الناس اللي يراجعون بسبب dyspnea because of cardiac disease. إذا أروح أنا بالريسبيراتوري ديبارتمنتس بالريسبيراتوري سنترز اقعد يجون الناس اللي عندهم كومبلين اوف شورتنس، اشوف معظم الناس الاندرلاين كوز مالتهم هو شورتنس اوف بريث. قسم قليل من الناس عندهم مثلا اذا اقعد بالاندوكراينولوجيكال او ميتابوليك سنترز راح اشوف معظم الناس اللي يجون عندهم هم ميتابوليك كوز اوف شورتنس اوف بريث. المهم بالموضوع انه these statistical data يعني it is variable. Sometimes he said cardiac is more common, sometimes he said lung disease is more common. It doesn't matter. Anyhow, all these lists you have to keep in your mind. Cardiac disease, just like decompensated heart failure, acute pulmonary edema, pulmonary embolism, all these. While the chest disease, COPD, bronchial asthma, pneumonia, metabolic disease, anemia, DKA, diabetic ketoacidosis, and uremia. These DKA and uremia شو يسوي لي؟ يسوي لي hyperventilations نسميه cosmal breathings in order to wash out the CO2 from blood لأنه البيشنت عنده acidosis فيهم يصير عندهم hyperventilation. لكن هذول أحيانا يجون ما يجون because of shortness of breath أو dyspnea. يجون just because of he feel ill, he feel dehydrated, he conscious, but when you examine him you observe this patient is hyperventilated. You say either the patient told you I have difficult breathing نسميه dyspnea، لكن إذا تفحصه وتشوف البيشنت hyperventilated تقول هذا tachypneic مو dyspneic. اوكي فعلى العموم الديسنيا the most common cause أول شيء dyspnea it is a symptoms not signs. يعني عادة البيشنت هو يقول لك أنا عندي dyspnea مو أنت observe it لأن هي feeling unpleasant feeling by the patients. So إذا البيشنت يجيك ويقول لك أنا عندي dyspnea shortness of breath تفحصه من تفحصه يعني ربما هو عنده normal breathing rates وربما عنده hypercapnia أو ربما عنده hypopnea بس هو عنده he said I feel I shorted breath. أحيانا يجي patients تفحصه هو عنده تاكيبينيا يعني respiratory rate مالته 30 أو 25 لكن هو ما يقول لك أنا عندي dyspnea جاي because of fever مثلا على سبيل المثال أو جاي because of hypotensions dehydrations. فبشي حالة شو نقول هذا البيشنت ما عنده dyspnea وإنما عنده تاكيبينيا لأنه dyspnea it is a symptoms while increasing in respiratory rate أو distress respiratory نسميها tachypnea. Okay, so the second symptoms is the chest pain. Chest pain, any unpleasant feeling in the chest, in the location of chest. Location of the chest extend from the neck to the upper abdomen. All these areas are called chest. Any unpleasant feeling, unpleasant sensations in this area, we call it chest pain. And the chest pain it can be extended from mild pain to the very severe pain. And the type of pain, this type of pain could be superficial, well localized from the chest wall, could be dull, originating from the inside the chest organs. إذا البين كان localized, superficial and localized هذا نسميه somatic pain وهذا عادة الكوز مالته من يجي من chest wall pain disease. لكن إذا pain originating from inside the chest, any organ inside the chest can giving chest pain. This pain will be dull, not well located, not well defined. So the chest pain can be somatic, well localized, or be dull, not well localized, not well defined. Here I will talk, I mentioned this because these are the serious cause of chest pain. These are conditions causing acute chest pain. If you missed it, you will lose the patients. So I only listing the acute chest pains, which is serious. And on the top of this, myocardial infarction, pulmonary embolism, pneumothorax, myocarditis, pericarditis, and aortic dissections, and bore heads rupture, يعني esophageal rupture, يسموها bore head syndrome. These should be not missed, because if you missed, you will lose the patients. So please keep this list in your mind. Any patient had chest pain, whether it is severe or mild, doesn't matter. You have to keep this point in your mind. Other points, just add chest wall pain or muscle spasm. This is not so important, just like this. So don't forget this. The third symptom is the cough. You know, the cough, it is very important symptoms in the patient who had respiratory disease. The patient, the cough can be any point in the history, whether it is cough or pain or any others. There are what is called memorizing system. يعني نقدر نتبع نظام يخلي الأشياء محفوظة بذاكرتنا. Memorizing symptoms. One of these memorizing symptoms هي نستخدم what is called mnemonic word. mnemonic words يعني شنو؟ نستخدم كلمة، هذه الكلمة بها حروف، كل حرف هو يرمز إلى كلمة أخرى، فيسموها mnemonic words. So these ski terms إذا نحفظها، هذه كل حرف يعني كلمة، فأنت تقدر تحفظ كلمة السكي تاغز ومن عندها تقدر تشتق الكلمات الأعراض اللي ممكن تسأل عليها. So what is the ski tags? Let me, first letter is side. So because I am dealing with the cough, so I will describe the component of this word about the cough. S letter is mean side. What are the side of cough? Sometimes cough originated from soreness of throat, from يعني pharynx. Sometimes cough is originating inside the chest, from deep chest. The patient can feel that, he can tell you about that. Quality, Q is equality. What are the cough? What are the sound of cough? Is it harsh? Is it dry? Is it barking cough? Barking cough يعني البيشنت يقح ويطلع صوت بالقحة كأنه صوت dog soundings يعني نباح الكلب، فكأنه دا يقح قحة تشبه صوت، فيسموها barking نباح يعني barking cough. So each of these characters giving you impression, you know, this cough could be due to something. And as example, harsh cough usually occur in the patient who had bronchitis. A dry cough usually occur in those patients who had pneumonia or early stage of pneumonia. Sometimes because of allergy of cough. I'm going to say with dry cough and allergic bronchitis. Now, على سبيل المثال, COVID-19 pneumonia, the most important symptoms is dry cough. Okay, so I will go more. What are the I letter refer to intensity? What are the intensity of the cough? Just this cough, prevent the person from doing his normal work or not. Just this cough puzzling the patients to prevent him from getting sleep or not. Just this cough associated with syncope or near syncope. You know what is the syncope and near syncope? Syncope, it means the transient loss of consciousness, while the near syncope patient he feel dizzy, drowsy, لكن doesn't lose his consciousness. فيسموه أما syncope or near syncope. Timings of this cough, T letters refer to the timings. What are the time of this cough? It is at night, at daytime, or all the day. Aggravating A letter to the aggravating factors. What are the factors lead to provoking this cough? This damp conditions, يعني مناطق مرطوبة أو smoking أو dust عجاج. relieving factors اللي هي يعني what are the relieving factors يعني من يوم يروح شو وقت يعني شنو القضايا اللي يسوي حتى تروح يلقحها مثلا changing his positions. واحد مثلا عنده pulmonary edema heart failure من اللي ينام يبدي يروح لأنه يصير congestion بالبرونكس فيقوم يقعد من يقعد تروح القحة فيقول لك أنا من أريد أنام supine positions ورا 5 دقائق تصير عندي قحة من أقعد تروح القحة فتعطيك impression إنه this patient could be called heart failure. Okay, what are the letter P? What are the previous similar episode? This patient had a previous similar episode or not? And the S here secondary symptoms. And what are the other associated symptoms with the cough? Adawiyal cough, chest pain, adawiyal cough, fever. These are secondary associated symptoms. Okay, let me talk about the cough reflex. Cough is a reflex. When I say it's reflex, I mean these actions need afferent pathway and stations for intervention of information, and then efferent pathways. So there are a reflex arc, يعني دورة كاملة من الأحداث. فبالنسبة للكاف، الكاف عادة الافرنت ريفلكس تكون موجودة بالابيثيليال membranes of the respiratory systems. حتى بالأسوفيجس موجودة، حتى بالهارت. These are cough receptors. Stimulation of these receptors leading to a cough. So we're sending signals across through the nerves اللي هو عادة الفيغاس نيرف. وين يروح للستيشن اللي هو المدلة اللي بيها الستيشن مال interventions of this information and integrating of this information, and then the efferent signals going through phrenic nerve to the expiratory muscles, and the process of cough occur. What are the cough يعني شو يصير عندنا بالكف؟ طبعا بالكف يصير عندنا during we got contractions of exhaling muscle and expiratory muscles, the diaphragm, abdominal muscles, expiratory muscle, internal intercostal muscle والabdominal muscle يصير بها contractions. Increase in the level of intrathoracic pressures because of these abdominal muscle and contraction, and these increased intrathoracic pressure associated with closures of the larynx. يعني يزداد النقط عندنا داخل الصدر مالتنا داخل الشيست بالوقت اللي الجلوتس is closed إلى أن يصل مستوى الضغط inside the chest مستويات عالية جدا، فبعد تنفتح وحده اللارynx ويبدي يطلع gush of air stream strongly flowing outside. These strongly and high speed flow of air من يطلع من الصدر ياخذ وياه شنو؟ كل شيء يجي بطريقه بما فيها البرونكيال secretions. إذا الكاف ريفلكس نستنتج من ذلك الكاف ريفلكس it is a protective reflex. الغرض من عندها for cleaning the bronchial airways from its secretions. طبعا بالمناسبة كل واحد من عندنا يطلع يوميا 10 إلى 20 ml of bronchial secretion daily, and this should be coughed out. كل واحد من عندنا يروح له مرة واحدة باليوم يمكن حتى ينظف صدره، مرة أو مرتين باللاوعي مالته. طبعا بالوقت الحاضر take care, don't cough in front of populations, لأنه this will lead other people will escape from you away, because the era of epidemic or pandemic of COVID-19. Okay. Possible cause of cough. عادة الcough يعني clinically we divide the cough into two types: acute cough and chronic cough. The dividing point هو times. Any cough stayed in the patients for more than 3 weeks, we call it chronic cough. Any cough less than 3 weeks, we call it acute cough. Approach to the patients with a chronic cough or acute cough is different. The most common cause of acute cough هي viral infection, يعني upper respiratory tract viral infection, just like flu, cold, or exposure to the allergens. يعني الاكيوت كاف مثلا على سبيل المثال بالوقت الحاضر من يجي واحد عنده كرونيك كاف، يعني ما اقول هذا عنده كوفيد 19، لانه الكوفيد 19 تسوي لي اكيوت كاف. يعني يجيك واحد يقول لك انا والله صار لي شهر ونص اقح، او صار لي شهر اقح، او صارت لي اسابيع الى شهر اقح. Don't go and jump to the diagnosis of COVID-19 and you making the patient anxious and his family anxious because you are taking non-judged, non-good decisions. الكرونيك كاف مثل ما قلنا هي الجاسترو، يعني الكرونيك كوز اوف كاف هي الجاسترو اسوفيجيال ريفلكس، اسما، بوست نيزل دريبس، tobacco, chronic obstructive airway, all these. Here in this table, the author used what is called subacute. Subacute هي gray zones between acute and chronic، يعني هي تمتد ما بين اسبوعين الى شهر. يعني it is not، يعني it's optional. You have to know acute and chronic. subacute يعني معناها اكثر من اسبوعين واقل من شهر. اكثر من شهر نسميها chronic واقل من اسبوعين نسميها acute. هاي الجراي زون السب اكيوت هي اللي تمتد من 2 weeks الى 1 month. The other symptoms هو sputum productions. As I said before, sputum productions usually normal person doesn't produce more than 10 milliliters of bronchial secretions daily. If it is increased, this will lead to a lot of cough, and this cough is a production, and this the production of this cough is sputum. We call this sputum, and this sputum classified to many types. The sputum clear or white or frothy and semi-mucoid, just like this. This is a frothy sputum. This is mucoid sputum. الفرothy sputum يعني وغف مي على شكل وغف، يقح وغف المريض. This is a very important signs of patient getting pulmonary edema. This is very important. You have to keep in your minds. يعني البيشنتس اللي عنده حاليا على سبيل المثال كوفيد نيمونيا او اني فيرال نيمونيا او اني بكتيريال نيمونيا، ما يقح وغف، ما يقح فرثي سبيوتم، ما يقح بيرولنت او ميوكو بيرولنت، لكنه مو فرثي. مين يقول انا فرثي معناه او ميوكويد معناه this patient either had pulmonary edema نسوي لنا فرثي سبيوتم، او ميوكويد نوت فرثي مثل هذا معناه البيشنت هذا عنده chronic bronchitis. If the patient got infections, the sputum will become mucopurulent، يعني it will become thicker and sticker. يقوم ما يطلع بسهوله، يعني يقوم يقح هوايه الله يطلع البلغم، تشلب ما يقبل يطلع، يسموه stick and thick sputums. If it is got more infection, this will become more thick and yellowish in color, just like this. If it is more يعني more and more infection, it will become greenish in color, dark, just like this. Okay, so the color, consistency, viscosity of sputum give you impression about the possible underlying cause of lung disease. طبعا these sputum sometimes, particularly if it is thick, viscous, sticky, if هتبقى inside the airways, it will close, يعني it will act as a plug and closed the airways, and this will lead to micro or macro segmental atelectasis. This is very important. من يصير عندنا atelectasis راح يصير عندنا hypoxemia because of ventilation perfusion mismatch. Okay. The other symptoms هو Haemoptysis. What are the Haemoptysis? Haemoptysis mean spitting out or coughing out the blood during the actions of cough. You should differentiate between Haemoptysis and Haemoptysis. Haemoptysis meaning the patient giving out the blood during actions of vomiting, while the patient with Haemoptysis giving this blood, gushing of blood by the actions of cough. So there are difference between these two. You have to differentiate between these two. And sometimes يجي أحيانا يجيك patient يقول دكتور أنا أتفل دم، يعني هو لا يقح ويطلع دم من عنده ولا يزوع ويطلع دم، وإنما يعني من ينظف حلقه يعني just يعني clearing his mouth and clearing his throat, he see just streak of blood. Usually origin of this blood is from the nasal cavity, from nasal sinuses and from nasal pharynx. This is not Haemoptysis. This is pseudo-Haemoptysis. So you have to differentiate between pseudo-Haemoptysis, between Haemoptysis, and between Haemoptysis. What are the massive Haemoptysis? Massive Haemoptysis, it means Haemoptysis, normal Haemoptysis, the patient coughing blood in the form of streaks of blood mixed with sputum. But when I say massive Haemoptysis, patient coughing out gush of blood, only blood. يعني يقح يطلع دم، ما يطلع streak of blood ولا يطلع mucus sputum mixed with the streak of blood. وإنما just blood. This is a massive Haemoptysis, and you should be cautious in dealing with the patients because this patient need immediate emergent interventions. When I say emergent interventions, not urgent, there are difference between emergency and urgency. Emergency, you have to do your work within minutes and hours، يسموه emergency طارئ. أما الحالة اللي تقبل تتأخر مثلا يوم أو يومين قابلة يعني ممكن الانتظار، نسميها urgent conditions. So there are emergent condition and there are urgent condition. لذلك أنت لما تروح للمستشفى خالين قسم الطوارئ، قسم الطوارئ شو يسموه؟ urgency department لو emergency department يسموه emergency department. It means this patient need immediate interventions to save the life of the patients. And these are the cause of Haemoptysis, and these are the mnemonic words used here. You can يعني call يعني take these words and recall it in your mind, and you can explain the cause according to the latter symbolizations, be bronchitis, bronchiectasis, aspergilloma, tumor, tuberculosis, lung abscess. All these diseases can lead to Haemoptysis. Take it in your minds. Okay. Now I finished the history. I will go to the physical examinations. When I going to examine the respiratory system, because before I going to examine the chest, I should examine the patient generally, looking for any relevant signs in general examination related or relevant to respiratory disease. So first I will do general examinations for signs relevant to the respiratory disease, and then I'm going to examine the patient chest. So the respiratory examination include the following: أول general inspections from the end of the bed. أوقف بنهاية البيد مال البيشنت وأعاين للمريض، أشوف الكونشسنس مالته، أشوف the patient is it comfortable or not, is it dyspneic or not, he's sitting or lying down in his bed. All these أسجلها as notes in my mind, and then I examine the hands of the patients and face and neck. Then I'm going to examine the chest examination based on the following component here: inspection, palpation, percussion, and auscultation. So as I said, first examine the patient generally, looking for any relevant signs related to the respiratory disease, and then going to examine the chest by following procedure, which is inspection, palpation, percussion, and auscultations. Preparations of the patients. If you want to examine the patient, you have to prepare the patient and prepare yourself for examination. First, you have to wash your hands in front of the patient in order to get the trust of the patients. Second, introduce yourself to the patients. Third, ask the patient permissions. Don't examine the patient without his permissions. And if the patient refuses to examine him by you accept this. Don't be nervous. Don't be aggressive against the patient. Yes, you have to accept it. From the patient's rights to his rights to accept anyone to examine him and to refuse anyone to not examine him. Okay, and then last one, you give him brief explanations to the patients before you start. The equipment you need to examine the respiratory patients, as you know, stethoscope, peak flow meters هذا نقيس الفلو يعني flow rates of the breathing of the patients. Usually عادة we keep the patients supine in the bed, supine, elevated head about 45 degrees. For the female patients, please, you have to remove the bra. Bra means يعني breast cover. Don't examine the female patient while she is wearing her breast cover, because you will get nothings by examinations. Okay, and then at the least, at the last, you have to expose the patient only when you are ready to examine. Don't keep the patients exposed while you are not preparing yourself. You have to respect the dignity of the patients. تحافظ على كرامة المريض. Don't assault him. Okay, physical examinations, general observations. مثل ما قلنا قبل شوية, you have to observe the patient generally about his comfortables or not, whether he had lying down or sittings, or he could tripod posture. All of these you have to note, and then you concentrate, you deal with the points related to the respiratory system. Here you look to the color of the patient, whether the patient is pale or cyanosed, whether the patient use accessory muscles or breathing or not. Does the patient is tachypneic or not? Does the patient had audible breathing sounds, just like wheezing, stridors? And also note the patient's respiratory rates and try to count it. Okay. I think at least count for 30 seconds. يعني تحسب الريسبيراتوري ريت مالته على أقل تقدير لمدة نص دقيقة. لا بس هي المفروض دقيقة، عادة احنا نحسب لمدة دقيقة. يعني you have to count the breathing rates of the patients. Here this diagram is showing you the respiratory muscles. These are inspiratory muscle. Inspiratory muscle, there are original inspiratory muscle اللي هي external intercostal muscles and diaphragm. These are original basal respiratory muscle. But if the patient going distress, need more oxygen, he had difficulty in taking in air, the patient will use accessory muscle of breathing, the inspiration, accessory muscle of inspirations. These include sternocleidomastoid, scalenes, and pectoralis muscles. Okay? While the muscle of expirations, there are no accessory muscle, there are no basal muscle of expirations. There are only accessory muscle of expiration اللي هي internal intercostal والabdominal muscle. ليش؟ Because the exhalations or expirations, usually it is inert process. It is automatic process. Doesn't need muscle to perform expirations. Only the recoil of the lung and the recoil of the chest will leading to the expiration. But if the patient got difficulty in expiration, he will going to use this muscle, internal intercostal muscle and abdominal muscle. So almost always regard the expiratory muscle is accessory muscle of expirations. Examination of hand. Inspection both hands. Look for fingers, for palm, for dorsum of the hand to see if there are cyanosis or clubbings or temperature. And you have to look for radial pulse of the patient's rate and rhythm and characters. And you have to look for bounding pulse or collapsing pulse if the patient had hypercapnia. And then check for flapping tremors, which indicate patient had type 2 respiratory failure. يعني معناه عنده CO2 retentions. Other body part examination, you have to examine just like the eyelids for anemia, you have to examine the legs for edema, leg edema, and the tongue for central cyanosis. What about flapping tremors? Flapping tremors, you have how to examine. You ask the patient to extend his hand in front of him while his wrist is dorsiflexed, just like this posture. How stretching his hand in front of him. The hand is dorsiflexed and the finger is extended upwards, and you look for irregular movements, for irregular jerky flexion, extension occur at the wrist or at the metacarpophalangeal joint. These irregular extension and deflections are these joints mean the patient had flapping tremor or what is called asterixis. ليش يصير عندنا flapping tremor؟ يصير عندنا imbalance between agonist and antagonist muscle activity due to disturbance in the diencephalon molar centers اللي هو موجود بالميدبرين. لذلك any disease affect on thalamus and hypothalamus and midbrain, it will lead to flapping tremor. So نتوقع الفلابينج tremor وين يصير؟ يصير بالريسبيراتوري فيلير، باليوريميا، بالستروك, all these, بالhepatic failure, all these can lead to flapping tremor. So flapping tremor is not pathognomic to respiratory failure, وإنما it can occur in other parts of organ disease.
دكتور what tar staining؟
What?
tar staining.
tar staining معناها التدخين، الإنسان اللي يدخن هواية يصير عنده yellowish discolorations of his fingers نسميها يلو دارك يلو، نسميها تار، يعني مخلفات اللون مال التدخين اللي يخلفه على السكين نسميه tar discoloration أو tar staining indicate this patient had smoke excessively or heavy smoker. Okay, what about the jugular other examinations اللي هو part of general examination and also related to the examination of the respiratory system اللي هو check the jugular venous pressures. As you know, jugular vein, there are external jugular vein and internal jugular vein. External jugular veins عادة يجي from outside extracranial blood skin here and come above sternocleidomastoid, superficial to the sternocleidomastoid, and then come down about the scalenus muscle going downward, backward. So إذا أشوف الكورس مالته external jugular vein شوف التورشس، يعني يجي هنا وبعدين يلف هنا ويدخل هنا. هذا التورشس long not straight way path of the vein, external jugular vein, make it liable for obstructions. لذلك الليفل هنا من نقيس الليفل مال jugular vein levels of venous blood here it is not real. ليش؟ لأنه هذا أحيانا دائما يصير به obstruction because of this long tortuous course. لذلك على من نعتمد على الانترنال jugular. الانترنال jugular هو ياخذ intracranial blood here from here and come below the sternocleidomastoid and going to the subclavian vein. اتحاد الانترنال jugular veins ويا subclavian vein شو يسوي لنا؟ يسوي لنا الانومينيت vein اللي يروح يسوي لنا superior vena cava. فهذا هو يكون عادة ستريت، وعادة احنا يعني we inspect this نشوف هنا اكو visible pulsation، ما راح نشوف الفين itself. هنا ممكن نشوف الفين itself بس هنا ما نشوف الفين، وانما نشوف pulsation of the vein underlying the sternocleidomastoid muscles. So you have to be careful. طبعا بالمناسبة during my career, during my professional life, I never remember I asked during examination, I asked any student to do jugular venous pressure assessment and examination of jugular venous pressure, and he do it properly. So all the students are defective in doing these. So please, you have to do it regularly. You have to see a lot of YouTubes to perform it because it is difficult science to discover. Anyhow, JVP, طبعا you have to hear, you see the upper level of pulsations, and then you put these at the level of sternal angles, and you assess the levels of pressures from here to here. فإذا طلع هنا 5 centimeters, then you add to this from the sternal to the center of right atrium 5 centimeter, فيطلع لنا level 10 centimeters. يعني عادة الليفل from sternal angle. طبعا احنا شو نقول؟ احنا هو هذا الشيء يقيس jugular venous pressure. jugular venous pressure شنو يعني؟ يقيس pressure in the right atrium, in the center of right atrium. The distance between the sternal angle here and the right atrium here is 5 centimeters. And from here to here level هم 5 centimeter. فتضيف هاي 5 سنتيمتر إلى اللي هي not measured، هي موجودة، يعني you can't measure it، بينما هي موجودة أصلا بالمعادلة، ضيف لها 5 فيصير عندك 10. طبعا هو normal JVP usually less than 8 centimeters. Any jugular venous pressure above 8 إلى 9 نقول this patient had increased right atrial pressures, either because heart failure or because of right ventricular failure or because of pulmonary hypertension. A lot of disease really increase in the level of jugular venous pressure. I want you to be skilled in assessing these signs because it's very important science for you to explain the underlying disease. Other examinations, you have to palpate for lymph node, cervical lymph nodes, اللي هي occipital, post-auricular, pre-auricular, submandibular, and anterior posterior cervical. أهم شيء scalene nodes. The scalene nodes here, you have to examine scalene nodes by press down gently between the clavicle and sternocleidomastoid. It's just like here. You just between clavicle and sternocleidomastoid, you push here your finger downward and toward the medially, downward and medially toward the vertebra. You will feel the nodes, these scalene nodes. These scalene nodes is very important. If you feel it, this patient had critical disease. And these scalene nodes doesn't enlarged by disease of the mouth or of the nose or of the ear, usually by disease of the chest. If this lymph node is palpable, enlarged, this patient has something abnormal in his chest. So be careful in assessing for scalene lymph nodes. Then we are going to examine the chest. Examination of chest عادة done by inspection, percussion, palpation, and auscultation. Inspections, you have to inspect a lot of things in the chest, the hair distribution, color of skins, any traces of skin damage, or any traces of previous operation scars or previous operations, any dilated blood vessel in the chest wall. And then you have to look to the shape of the chest. Shape of the chest, there are a lot of different types. One of these is barrel chest. You see, this is normal chest. Normal chest and transverse diameter usually larger than anterior posterior diameters. The patient اللي يصير عنده emphysema, يصير عنده inflammation of the lungs, ويسوي what is called barrel chest. Barrel chest معناه شنو؟ the patient increase in the anterior posterior diameters and become equal to the transverse diameters. Other chest abnormality pictus calineatum يعني أو pictus excavatum يعني funnel chest and pigeon chest. Okay, Harrison sulcus, and sometimes patients had Harrison sulci. Harrison sulcus here singular or plural or Harrison sulci. What is the Harrison sulci? You see, this is patient, this is young baby. You see this depression here and depression here. These are called Harrison sulcus. Let's just say Harrison sulcus. And this patient at the rickets. الريكتس شو يسوي؟ يسوي البون تكون soft. عادة احنا الدايفرام مالتنا وين يتصل؟ يعني عادة insert to the origin or insert to the ribs. So continuous contractions of the ribs, continuous contraction of the diaphragm will pull inwards the wall inside. So هذا حيطلع لي Harrison sulcus. So don't forget, these are Harrison sulcus. Occur in blue spawn الريكيتيك patients. ليش يصير عندهم؟ لأنه continuous contractions and movement of diaphragm lead to these depressions. Other signs of rickets اللي هي يسموها rickety rosary. You see here طبعا الريبس مالتنا يصير بي costochondral يعني اكو costal part bony part واكو cartilaginous part. The conjunctions between bone parts and cartilaginous part نسميها costochondral junctions. Here in costochondral junction يصير overgrowth of this area ويسوي لي هذه rickety rosary. نسميها rickety rosary ليش؟ لأنه مثل الخرز مال المسبح rickety rosary. بس هي ليش يصير؟ نتيجة rickets. For any patient have these two signs, معناها this baby had vitamin D deficiency and have rickets. Kyphosis and scoliosis يصير عند الناس الكبار، معظم الناس الكبار اللي عندهم osteoporosis. The breathing pattern, you have to look at the breathing patterns. يعني there are different type of breathing patterns. واحد عنده hyperventilations، واحد عنده bradypnea، واحد عنده cosmal breathings and Stein breathing. يعني a lot of different type of breathing you have to know, and you have to be able to recognize its asymmetry of the movement إذا كان البيشنت عنده any asymmetrical movement in his chest wall. يعني عادة احنا من ناخذ نفس ونعطي نفس، عادة الموفمنت of our chest تكون symmetrical. فإذا صار asymmetry between the movement معناها the patient had abnormality in that side of the chest which is not moved. Palpations of the chest عادة يعني you have to palpate for any point of pain in the chest, and then you have to palpate for the positions of cardiac apex. You have to palpate for the positions of the trachea, and you see whether it is deviated or not. And then you have to measure the expansion of the chest during full inspirations. And there are two methods for assessments of chest expansions, either by regional assessment and regional chest expansion measurements by this regional يعني هنا نسويه وبعدين anteriorly، أو باك circumferentials نستخدم هنا يعني graded tapes. Okay, here are circumferential chest expansion by using calibrated tapes around the chest, and you measure the chest expansions. Usually, the chest expansion normally during inspiration take about 5 to 6 centimeters. يعني أنا من أخذ نفس عميق ال circumferentials measurements increase about يعني محيط الصدر مالتي increase about 6 centimeters. Any patient got less than معناها less than this معناها the limitation in the chest expansion either because of lung disease or because of chest wall disease. Okay. Second, we have to examine the patient chest by percussions. Percussions عادة you start from the clavicle and downwards. Don't percuss above the bone. Usually, these are golden rules. Don't forget it. Don't percuss above the bone. Okay. You should able to recognize different types of percussions sound you hear. يعني عادة أما tympanically هو normal أو hyper resonant إذا patient عنده hyperinflation of chest، أو dull إذا patient the dulling of sounds يعني ما يصير عنده vibrations مال sound فيسموها dull. وستوني dull إذا كان أكو pleural effusion. ستوني dull هو تسوي percussion على الحائط، أي جدار يمك تسوي percussion يعطيك stony dullness echoing sounds. طبعا each area of the chest correlate to the lungs lobes. عادة احنا lungs بيها يعني right lung بيها 3 lobes، left lung بيها 2 lobes. عادة الانتيريور upper lobes عادة upper lobes يكون يشغل anterior wall، lower lobes يشغل posterior wall، والmiddle lobes أو lingual lobe مال left lung تشغل عادة lateral wall. So percussions auscultation in this area indicate which lobe got pathology. يعني إذا أنت صار عندك مثلا signs of bronchial breathing in the anterior chest wall معناها ال upper lobe is involved by pathology. إذا صار عندك abnormal signs بال posterior chest wall معناها this patient had pathology in the lower lobes. And so percussions, and then percussions be rules The rules you have here, if you look here, you have to put the middle finger, press it forcefully, and other fingers elevated, not chest, not touch the wall. Only you have, these are the percussion based fingers. خليه. والهذا السكند، هاي الايد الثانيه نستخدم بها الميدل فينجر فور سترايكينج. فهذا شو نسميه striking fingers, and this hand is striking hand, while these are percussion based fingers او percussion basal fingers. So هنا عادة نستخدم striking fingers by moving off the hand from the wrist. Okay, not from the elbow, from the wrist. And usually when you percuss the middle phalanx of basal percussing fingers. So this rule, you have to apply this rule in order to get the proper sound you hear. Auscultations, you have to use your stethoscope for hearing the sound. So if you define what is the process, what is the auscultations? Auscultations is the processing of listening, usually with the stethoscope, to sound produced by movement of gas within the chest. The most common respiratory sound you hear here, rails or crackles, rails or crackles. Small crickling, wrangling sound you hear during inspiration. Bronchi عادة sound هنا نصير because of low pitch sounds. Musical low pitch sounds originating from large airways, either because of obstructions, narrowing of the airways, or because of presence of secretions in the airways, making it narrow. Stridor, it means they are musical sound usually heard during inspirations and the first part of inspiration. And these stridor usually indicate this patient had upper airway obstructions. Wheezing, it is high-pitched sounds usually originating from small airways because of constrictions, airway narrowing or constrictions, and these usually heard in the asthma and bronchitis. Normal breathing sound is vesicular breathings. And in the upper chest, you can hear bronchial or bronchoalveolar breathings, which is here the area near the chest wall, and in which the bronchus تكون superficial near the chest wall. ولذلك لما تخلي السماعة مالتك بالupper part of the chest شو راح تسمع؟ راح تسمع bronchoalveolar or bronchophysicular breathings. So usually لما تخلي السماعة مالتك على التراكية تسمع tracheal breathings. لما تخلي سماعتك على upper part of the chest near the sternum, near the sternum, يعني second intercostal space parasternally تسمع broncho physical breathings. ليش؟ لأنه هنا تكون التراكية superficial تنقسم إلى two bronchus, primary bronchus تكون superficial فتسمع الاير فلو in this اللي هو يعطيك bronchophysicular. بعدين in other part of the chest as a whole تسمع physicular breathings. Each sound of this sound had particular characters. You have to hear it by YouTubes, and you have to know what are the difference between them. Okay, after the lecture today at night, inshallah, you have to open YouTubes and hearing these sounds. It is very easy to differentiate between these sounds. The area or the point in the chest you have to examine by stethoscope and by percussions here extend from the clavicles and then parasternal area and then laterally to the axillary area. You see percussion here, don't use percussing basal fingers, but you strike the bone directly. This is very important. Strike the clavicle directly without
دكتور بلا زحمة صوت انقطع.
ايه تسمعني هسه؟ منقطع الكهرباء، تسمعوني هسه؟
ايه تمام.
اوكي منقطع الكهرباء هسه. اوكي فاذا تسمعوني يعني shall I going to continue in the lecture or
كمل دكتور، كمل براحتك.
ترى لو زحمة هاي بس الفحص الأخير تقدر تعيده بالعربي إنه مال الكلافيكل.
هنا المهم بالموضوع انه مبتدئين مسوين percussions من تبدين من الكلافيكل upward، ما تستخدمين يعني الهاند تسوين يعني تخلين البيزل فينجرز والسترايكينج فينجرز، وانما يو سترايك ذا كلافيكل دايركتلي باي ذا سترايكينج فينجر، ما تخلين هاند، يعني ما تخلين اصبع وتدقين عليه بالاصبع الثاني. اوكي
بلي دكتور.
the percussions on the clavicle bone يصير direct percussions مو indirect percussions. If you use your fingers يعني percussing finger and striking fingers معناها you percuss the persons indirectly, but if you have to percuss the clavicle يعني lung under the clavicle, don't use percussing basal finger, only you use the direct striking fingers. Okay. Okay. After you finish your examinations, you have to cover the patients, to redress him احتراما إله, thank the patients, and you send him for bedside test, the temperature, peak flow meters, and that is all. And then you have to inspect the sputum. Don't say that is nauseating. Almost always, sometimes even particularly the chesty patients, when he come to you, he come sometimes with a cup or hand covered chief بها sputum مالته. You have to inspect the sputum. Don't be nauseating and don't go away. Okay, you have to look to the sputum of the patient. أولا ينطي معلومة عن البيشنتس disease، ثانيا احتراما للبيشنتس اللي جاي بالسبيوتم مالته وجاي. Okay, that is all, and I thank you for your attention and attendance. Any questions? No, any questions?
دكتور بس الحضور بلا زحمة.
مو انت مثل ما كل مره صلاح دز لي، لان انا عندي القائمه مالتي ما تطلع بها الاسماء بالعربي، تطلع هيك مخربطه.
تمام.
يا عمو شكرا جزيلا.
دكتور زحمة.
نعم
بس سؤال، اكو هاي مال السكالين نود، هاي ايش ممكن تصير بها سبولينج؟ انت اذا تقدر تعيده.
السكالين لف نود، يعني احنا شوف عندنا سيرفايكال لف نود اللي مثلا جابيولار والمنتال لف نود والبوست بيكولار، يعني هذه ممكن تصير مثلا واحد عنده بلاعيمه ممكن هاي تلتهب، واحد عنده بلاعيمه توجعه بالعون يعني تونسلايتس فنجايتس ممكن تلتهب. يعني هوتايتس
يعني انفكشن، يعني مو انفكشن،
هي انفكشن يعني تلتهب يصير بها انلارجمنت. طبعا هي يعني احنا الكوز مال enlargement of lymph node many cause، واحده من عندها infections اللي هو most common. الاذر كوز هو المالجنسي والليمفوما، مو صحيح؟ والاذر كوز اني سكندري اني سوليد تيومر سكندري ميتاستاسيس. احنا عاده الموست كومن هو الانفكشنز. من يصير عندي enlargement lymph node فانا شو اقول هاي انفكشن او مالجنسي لازم ماركر، لكنه من اجي ابحث السيرفايكال lymph nodes اللي هي يعني سب مانتال والجيجولار والاوكسيبت، لاني يعني دائما بالالتهاب مال الفارنكس والابر ايرويز يعني الريسبيرتوري ابر ايرويز يصير بها انلارجمنت. فانا عاده ما اكون قلق عليها، انتظر مثلا اسبوعين ثلاثه واقول له تعال. لكن من اشوف اكو سكالينيوس lymph node enlargement اقول هذا البيشنت عنده something is wrong in his body، اما عنده chest يعني chest infection مثلا تي بي او ليمفوما او malignancy بالchest مالته، او عنده patient lymphoma. So here I deal with the patients يعني cautiously، مو راسا ادز على chest اكس راي، راسا ادز على سي تي سكان، ما انتظر 3 اسابيع. اوكي
اوكي دكتور، زين بعد سؤال دكتور.
يلا.
هذا مال البركشن
نعم
بالبوستيريور وول والرايت لاترال وول، يعني انا شايف عليها فيديوهات تقريبا نفس الصوت، يعني شلون واحد راح يفرق شيء؟
باي يعني دي يعني هذه القضايا، هذا سكيل. السكيل ما حد يقدر يعلمك يعني اياه، يعني ما حد يقدر يعطيك سكيل. السكيل you have to gain it by yourself. يعني انا ما اقدر اقول لك شلون تفرق unless you do it, you experience it, you practice it. فهذه يعني بالخبره تجي عمو.
واضح دكتور،
بالخدمه.
شكرا.
دكتور لو زحمة
نعم
بالكف ريفلكس احنا مو قلنا انه مرات تصير انفولنتري، يعني لازم اكو ستيموليشن يصير مثلا لو كيميكال لو ميكانيكال. زين دكتور بس ولو زحمة مرات مثلا بالفحص يقولون المريض قح، يعني فولنتري كف يصير هنا شلون يصير يعني شلون هم نفس الريفلكس لو لا؟
سيم ميكانيزم. البيشنت هنا هي closed his lungs and then increase intrathoracic pressure and then cough. This is voluntary. عادة can do it. Yes.
اقصد الريسبترات.
ها
اقصد الريسبتر، يعني ماكو ستيموليشن للريسبتر، يعني ماكو مثلا فد جزيئات لو فد شي يسوي ستيموليشن للريسبتر بحيث يقح. فشلون انه تصير هاي العملية؟
تصير العملية by يعني by sending signals from your brain to the medulla, from the medulla to the abdominal muscle to increase intrathoracic pressures. These done by your will, consciously, by erratic يعني by your will consciously, but here mainly occur as a reflex. So a reflex ممكن انت يصير spontaneously، لكن ممكن انه انت يعني تسويه by your will voluntarily. اوكي
دكتور يعني بالفولنتري انه بس افرنت ماكو افرنت، مو صحيح؟
مو عن هاي مع يعني انا ما طبيها بالموضوع، ماكو افرنت. يس يو ار رايت، اي ثينك يو ار رايت. بس المهم بالموضوع انه الفولنتري كان يعني الكف كان بي دوينج باي يور ويل. صحيح ماكو ستيميليشنز، لكن راح تيجي اوردرز من السيربرال كورتكس، motor cerebral cortex to the middle, to the brain stems, to the middle brain, and then going into the brain, to the middle oblongata, and then going to the phrenic nerve or to the abdominal muscles and doing these actions of cough. Okay. لكنه الكف عادة it is a reflex. يعني البنفيت مالته الموجودة مو as a voluntary actions. البنفيت مالته تجي من الريفلكس بوزيشن مالته، يعني when the stimulations of these cough receptors occur by any irritant, the patient will cough it in order to clean his airways. That is the very important thing, important point you have to keep in your mind. And I hope you benefit from these lectures, and I do my best really, and I hope for you good years, good life, and good health. والله يحميكم وعوائلكم ان شاء الله من هذا الكوفيد 19، ونشوفكم ان شاء الله بصحه وعافيه. Any other comment?
عاش الدك دكتور، شكرا.
Thank you. مع السلامه.
الله يعافيك.